Good afternoon. Welcome to another edition of McMaster Perspectives. We are recording in Krakow, Poland, during McMaster International Review Conference in Internal Medicine. We have a privilege to host a number of prominent academicians and clinicians, among which we are welcoming Professor Gordon Guyatt from McMaster University. I could say a lot of things about him, but I would consider him a leader in the revolution of evidence-based medicine, something what we lived through last few decades. Gordon, for uninitiated people who hear about EBM first time or who heard it many times but don't necessarily thought about it, how would you explain the issue of EBM? Where did it come from and where is it today?
Okay, in terms of where it came from, clinicians nowadays do find it hard to imagine what life was like before evidence-based medicine. And it's only people of our vintage who can really remember. What life was like before evidence-based medicine when clinicians had a patient with a problem and they weren't sure of what to do. They would rely on three things. Number one, they would rely on physiologic rationale. They would think about the physiologic situation and they would make deductions on the basis of their understanding of the physiology. And then they would think of practical experience. They would think of their own practical experience, what happened when they saw patients like this before, and when they tried this and that, and see what happens, and they would think about that. And the third thing is that their own practical experience, but also their colleagues' practical experience, who they talk to and so on. And then they would think of the experts, the authorities, and what the authorities might have to say about those situations. And relevant to this, the authorities would be using the same sources of information. They would be using physiologic rationale and their personal experience. It would never occur to anybody to go to the original literature. And if they did go to the original literature, they would have no idea how to distinguish what was trustworthy from what was untrustworthy. And that was the way the world was. So when EBM came along, it now said, in addition to those other sources, which one should perhaps be a little skeptical about those other sources, there is another source that you can go to. And you can go to the original literature and see what it has to say. And that required a structured approach. So you couldn't just go and look at anything. You would have to say, okay, what is the question to which we are going to the literature? Because using the literature to answer your questions requires a structured question. And we found a nice structure for our questions. And we call that structure PICO, for patients, interventions, comparator, and outcome. So that's the first thing that clinicians, when they are using the literature, when they're going beyond what they used to use and using the literature, to use the literature effectively, they have to come up with a structured question: patients, intervention, comparator, and outcome. So then they go to the literature and they look for evidence addressing their PICO. And they have to search for the information, and they then search for the information using that structure, and that structure conditions their search. And then they, or somebody, and we'll come to that, has to be able to apply rules of evidence to decide on the trustworthiness of the evidence they have and what its appropriate interpretation is, and then bring that information back to the individual patient care. I think I'll add one more crucial thing. And that is that the other thing that emerged from the first years of evidence-based practice, so that's what we were doing. For the first time, we were adding this additional element. And we were also saying this additional element is very important. And as a matter of fact, if the evidence is moderate or high quality, it trumps all the rest, right? Whatever came out of your physiologic rationale or your personal experience or the pontification of the experts, what you're going to get from the evidence from the medical literature will be a superior guide to how you manage this patient than all that other stuff. And then there was one additional thing that emerged from our first years of evidence-based practice, which is somewhat ironic. Having gone through and found the evidence, it never tells you what to do. Why not? It doesn't tell you what to do because there's always trade-offs. There are, when you're thinking of your intervention versus your comparator, there are some things that are better about the intervention and some things that are better about the comparator. All our interventions, for instance, have adverse effects. And then we must trade off the good things about the intervention and the not so good things with the good things about the comparator and the not so good things. And that requires values and preferences. The treatment may lower the risk of stroke, but it may increase the risk of serious gastrointestinal bleeds by more than it lowers the risk of stroke. What does one do? The evidence doesn't tell you what to do. It's how the value the patient places on the stroke reduction versus avoiding the gastrointestinal bleed. So that is a picture of the world before EBM and how EBM really transformed the world of delivering clinical care.
As you were describing this evolution, it struck me how time and skill consuming this process is.
Yes. So as it turns out, what I described was our initial somewhat naive notion of evidence-based care. When I started in 1990 directing the internal medicine residency program at McMaster University, I thought it was going to work exactly as I just described it to you. We were going to train these doctors so that they would identify their PICOs, they would go to the medical literature, they would find the studies, they would evaluate the studies and bring it back. After 7 years running this program, I realized just how naive this initial notion was, and that it was completely, in fact, unrealistic. It is right in its fundamentals, but the big difference is it isn't the clinician going out and doing the search and finding the relevant evidence and evaluating the relevant evidence and coming to the appropriate conclusions. It's somebody else doing that. It's people who have the time and expertise to search for the right evidence, find the right evidence, do the evaluation, make the appropriate interpretation, and as the way the world has evolved, provide guidelines as to what one should do. The clinician is still identifying the PICO. It still has to be, the clinician has to decide what actually am I looking for. So it still requires that skill, but instead of going out and doing the whole evidence search and appraisal, that is left to some people with both content area expertise and methodologic expertise to do that. So the physician then finds their PICO, goes to their best source of evidence summary and recommendations that they know, and brings that back, understands the evidence. The clinician still needs to be able to understand the evidence and understand the evidence summary to go back to the patient and do shared decision making, but all the work of searching, summarizing, processing, and often coming up with a recommendation, that's left to other folks.
And what you are describing now is probably process of generation of clinical practice guidelines,
Yes.
which are so common in our today's life. I sometimes read that for the first time the phrase clinical practice guidelines was first used in something like 1992, which seems a long time ago, but it's difficult to remember the world without those.
It is difficult to remember the world without evidence-based medicine, and it is difficult to remember the world without practice guidelines. And indeed, the young physicians, or even not so young physicians, are fundamentally ahistorical. A little joke I have is, if you asked a typical medical student, when do you think evidence-based medicine got started? They would say, 1850?
Yeah, maybe it did. We simply didn't know about it. If we are talking about this process where the evidence is searched for and summarized and presented to you, could it, and in form of practice guidelines, could it not lead to cookbook medicine, so to speak, when everybody will behave in similar way?
So to start with, little correction, you said when the evidence is summarized and so on in practice guidelines. The practice guidelines provide, as is implied in your question, some direction. And so that's an additional thing. It not only says, here's the summary, folks, but it provides some direction as well. And why it is not cookbook medicine, there's two different situations. One situation is the way, and we haven't mentioned it yet, but there is evidence-based medicine has been hugely influenced by what we call the grade approach to rating the certainty of evidence and moving from evidence to recommendations, which now is at the core of evidence-based medicine. And this grade approach says on the process of moving from evidence to recommendations, there are strong recommendations and there are weak or conditional recommendations. And the strong recommendations are just do it recommendations. And if you wanted to call those cookbook medicine, well, you could, but that would not be a bad thing. So for instance, a patient comes into the emergency room with a myocardial infarction, and the question is, should that patient use aspirin? Well, the benefits of aspirin in these situations, they will reduce the risk of dying by 25% with almost no adverse effects whatsoever. Well, if it's cookbook medicine to say, give that, don't sit and have a little discussion with the patient, say, please take the aspirin, this will help you. Okay, if you want to call that cookbook medicine, fine, but that's good. That's the way it should be handled. When we have strong recommendations, which means the benefits clearly outweigh the harms, without a doubt. If you took 100 patients and told them, I made them understand the evidence, all of them or almost all would say, yes, please, let's do that. Clearly the benefits outweigh the harms. But that is not the typical situation. In fact, you can correct me if I'm wrong, I know this for another resource, but I would suspect that McMaster Textbook of Medicine has 2/3 of the recommendations are weak or conditional recommendations, which means no cookbook, which means that the right thing to do will differ in the patients depending on their particular circumstances and their particular values and preferences. Most of our decisions are value and preference sensitive. And that means that the clinician has to understand the evidence and to have the skills of communicating that evidence with the patient and working with the patient to make the right decision for that patient. And there's nothing cookbook about that.
Well, in some situations, you mentioned this conditional or weak recommendation or suggestion may depend on the trade-offs. But sometimes we also have no trust or no too much confidence in what we know. How the EBM practitioner should deal with situations where we don't have strong data, where we don't know exactly the consequences of one.
Well, let me give you an example where before we understood the importance of the certainty of the evidence, things went terribly wrong. And that was with hormone replacement therapy for postmenopausal women. Well, there was a point where we had non-randomized studies that suggested big decreases in cardiovascular risk with hormone replacement therapy. And the international medical community bought into this, and they started telling primary care physicians, tell your women, older women patients or middle-aged women patients, depending on how you define it.
Be careful.
Yeah, I'm being careful. Get them to take hormone replacement therapy to lose their cardiovascular risk. And this was widely done. And then the randomized trial find out that hormone replacement therapy did not reduce cardiovascular risk and had other problems associated with it. And it became evident that it was absolutely the wrong thing to do, to tell all these women, this reduces your risk of cardiovascular events and you should be using it. And it was very disturbing for many family doctors who'd been taking the advice of the experts who were saying to do this. Well, how should it have been done? How it should have been done is, well, we have preliminary evidence, which is not great, that this may lower your cardiovascular risk, but we also have evidence that it does some not so good things. Given the possibility that it lowers your cardiovascular risk and the possibility or the probability that it'll do at least some bad things, you interested? And that would have been the appropriate way to handle that. So in other words, when you do your shared decision making, it has to be with an understanding of the quality or certainty of the evidence. And that is, I hope, illustrated by what I said, that your decisions are going to be very different if you say, we know it does this good thing, or, well, maybe it does this good thing, but we're not at all sure.
Gordon, you are a full-time practicing clinician. How do patients react to situation where you come and say, this is 1, 2, 3, you take it, thank you, you'll be fine, versus, you know what, we are not quite sure what to do, but on balance, that would be my suggestion. What do people want? What do patients want?
In my experience, patients can deal with the uncertainty that you present them with, and they may come back to you and they may say, well, doctor, what would you do? But my answer to that, I'll give a real world example. I had an individual who was taking anticoagulants for atrial fibrillation and came in with a large GI bleed. Well, we got through the GI bleed and it came time to leave the hospital. Should that patient restart the anticoagulant or should they not? Well, we had obviously their risk of bleeding when we restarted the anticoagulant was much higher. Couldn't put a good exact number on it, but much higher. And we know how much it reduces the risk of stroke. So the question is, do you take it or not? And the patient said, well, doctor, what do you think? What would you do? And I said, well, tell you what, I am personally really terrified of a stroke. That would be really horrible for me. I've never had a GI bleed. I know basically what it is, and you get better from a GI bleed. You've had a GI bleed. You know what it is. Okay? So if it were me, because I am terrified of stroke and I know GI bleed is bad, but it's not that bad. And so I would resume the anticoagulant. But that may not be, you've had the GI bleed, you know what it was like. And so you are in a way more informed than I would be in making the decision. If you're like me and you're terrified of stroke and you say that bleed was not pleasant but not so bad, then you will use the anticoagulant. If on the other hand you feel like, well, this bleed was horrible, I'm not so frightened of stroke, you wouldn't.
Well, thank you for this part, Gordon. What I would like to do now is to talk about something called core grade, which I understand you are just publishing as a series of articles. It may be of interest to some people who are familiar with grade, but maybe you could describe to us the I would say history of grade, and then why core grade became relevant to you.
Okay, so we talked earlier about the fact that clinical practice guidelines started in the early 1990s and became fairly quickly very influential. And unfortunately, the first approach to clinical practice guidelines was an approach we call GOBSAT. GOBSAT stands for Good Old Boys Sitting Around a Table, and that's what it was. Not particularly informed, not particularly evidence-based. The folks making up the guidelines were not experts in understanding the evidence, and in many cases they weren't that interested in the evidence. They were back to physiologic rationale and their personal experience. Well, as things evolved, people, as evidence-based medicine took root, people started to think, oh, maybe this isn't such a great way of making the guidelines. And then what was needed was a structured approach to saying, how certain can we be about the evidence? Is this the evidence that we really know what happens? We really are sure? Or is it back like it was with hormone replacement therapy, where we thought maybe it reduces cardiovascular risk, but maybe it doesn't, and it turned out it didn't. So which of these situations are we in? And of course, you could think of it as a dichotomy. We're really sure or we're totally unsure, but it's actually a continuum between we're really sure, well, not quite so sure, or really uncertain. So something is needed to tell us where we are in this continuum of certainty of evidence. And then something is needed to tell us, once we have the evidence, how we go from evidence to recommendations. And so how do we do that? Well, we better be very clear on what the benefits are. We better very clear what the harms are. Better very clear what the burdens are. And we better be very clear whether there's high quality evidence or low quality evidence. And we better be clear on patient values and preferences, which are crucial for the trade-off. So we need a structured approach to deciding on how certain we are about the evidence, and a structured approach of going from evidence to recommendations. And a group of us said, well, guidelines by 2000, they were getting the idea that maybe we'd better have some idea about the certainty of the evidence, and we better have some idea about the structure of going from evidence to recommendations. But there were many systems around. Most of them weren't well worked out. It was complete chaos. And so a group of us got together and said, can we come up with something that is really scientifically sound, that people will look at it and they will say, this makes sense, and that we will be able to describe it to them so they could apply it. And we came up with this approach of grade to rating the certainty of the evidence and moving from evidence to recommendations. And as it turns out, in the course of my career, I've had some what I still think are great ideas that nobody paid any attention to. And sometimes I had, fortunately, EBM being one of them, great ideas, obviously, along with other people we were working together. Anyway, that there was great uptake. As it turns out, grade was one of the hits. Grade was one of the winners. So there's now over 120 organizations worldwide that is using the grade approach. They include the World Health Organization and the major American groups like the American Thoracic Society, the American College of Physicians. They include the Cochrane collaboration, which insists appropriately that all its systematic reviews be done using the grade approach. And it includes the McMaster Textbook of Medicine. So there are among these 120 organizations using grade, some very prominent ones. So great. And then we started writing all these articles about how exactly to judge the certainty of the evidence. What are the details of the rules of deciding whether it's high, moderate, low, or very low quality evidence? And what are the details of the approach of going from evidence to recommendations? And that was great. And in a series of papers in a methods journal, we laid all this out, about 15 papers. And that was fine. Well, we'd done that by 2015, we'd done that. But we kept going. And we said, we can fine-tune this, and we can fine-tune that. And maybe we were a little wrong about that one, and let's correct it. And let's make it really sophisticated. And so another decade later, problem. Grade has got too complex for many people, and there's now 50 or more papers out there describing grade. Who can keep track on what is the latest? Very few people. So grade is becoming less useful because of this complexity and resulting confusion. So what are we going to do? Well, our idea is to take the essentials of grade, which we call core grade, and lay it out in a relatively brief series of papers that will summarize it and give what I am thinking of as one-stop shopping. You don't have to look at all these 50 grade papers that have been published before. Here are what's going to turn out to be 7 papers into BMJ that provide the whole picture of starting with formulating your PICO, your target PICO for the question of your interest, right down to rating collecting, summarizing the evidence, rating its certainty, and moving from evidence to recommendations, all in a series of 7 papers, which we are calling core grade. And I think the first 3 have come out now. It seems to be again one of the times I think we're at the right time in the right place, which is what you need to be to get uptake. People, I think, will realize that this is really something needed, and it can, in the most optimistic assessment, it will be revolutionary for grade. In other words, it will take us back to where grade was at the beginning to say, wow, this is really the way we should do things. And people say, wow, one-stop shopping in something that is, the process is not simple, but as simple as possible. And as clear as possible.
So if you could move from 50 longer papers to 7 written in a simpler language and on a more practical level, I'm sure it would be well taken.
Well, we believe we've done it. We'll see.
We'll see what we'll do in another 10 years, but maybe somebody else will be doing it. Gordon, thank you very much for taking us through the history of EBM, history of grade, and core grade. Thank you.
It's been my pleasure.
Thank you very much, and till the next time.